Hello, everyone. Thanks for joining. Today's session, we are going to go through AMD. And after sort of discussing AMD and wet AMD, I'm also going to touch on kind of other vascular disorders that can happen at the macula, other causes of CNVs, and things to consider when trying to come up with some differentials as to what's in front of you. As an introduction to AMD, I mean, many of you will already know this, but it's the leading cause of blindness in the Western world, especially in the over 50s. And the older you are, the more likely you are to have it, with the prevalence increasing as the age increases. And there are some risk factors associated. It's usually people who are of a Caucasian descent, females, smokers, those with a sort of cardiovascular risk factors are also associated with the development of AMD, and there's also an association with hypermetropia as well. Very, very common, and in terms of a cause of blindness, very much the sort of thing that you're going to see a lot of, especially if you're working in the developed world. Now, today's session, like I said, I wanted to sort of talk about dry and neovascular AMD, separate the two and discuss what your treatment options are, how to investigate it, how to treat it. And then we're also going to talk about other macular disorders as well, near the end of the session. So dry AMD will be sort of 90% of your cases coming in with macular degeneration. It's by far the most common type of the two, and it's essentially categorized by it's characterized by loss of the RPE. And in the early stages, it's very much asymptomatic. So patients usually don't know it's developing. They may have come in for example, a cataract review, and then on an OCT, you might notice some sort of age-related changes at the back, and it could be asymptomatic in the early stages, and then they progress into the late stages. And in terms of that progression to the late stage, a lot of it depends on the type of drusen, how big they are, and any pigmentary changes in terms of what risks that eye holds to progress into the late stages. AMD is sort of categorized based on a sort of universal categorization where you have either no AMD at all, and then you progress from sort of early AMD to intermediate to advanced. Your early AMD are sort of a few small drusen. Intermediate are where you start to get slightly larger drusen or potentially large drusen, and then your advanced AMD is when you get this introduction of a geographic atrophy. For the purposes of your exams, there are certain criteria for what small, intermediate, and large drusen are. I believe small is anything less than 63 microns, and then between 63 to 124 are your intermediates, and then anything above 125 microns is a large drusen. Now, clinically, how do you really tell what a large drusen is? Essentially, if you actually use your retinal vessels, so these main branches are approximately 125 microns wide. So if you sort of look at the rim of the optic disc there, that's roughly 125 microns. So a drusen that's that big or more, you're looking at a large drusen, and you're looking at intermediate AMD, with a risk of progressing into end stage AMD. So when it comes to diagnosing it, you're probably going to do some photography of the fundus. You'll do an OCT. You'll probably want to do an OCTA to look for any potential CNVs, and you might want to consider doing an FFA as well if your diagnosis is unclear. But essentially, that's really what you're going to use to diagnose the AMD. Now, managing dry AMD tends to be supportive, mostly. So it's things like, getting them in touch with the Macular Society, support groups, getting them registered if they require it for being sight impaired, talking about lifestyle changes, getting them into the low vision clinics, potentially an eye care liaison officer if you're in the UK. And there are some vitamin supplements that you can suggest to the patient based on the AREDS formulation. So for your exams, again, AREDS 1 looked at vitamin C and E with beta carotene and zinc, and then it showed beta carotene increased the risk of lung cancer in both current and ex-smokers. So the AREDS 2 removed the beta carotene, replaced it with lutein and zeaxanthin, and found that it didn't carry the risk of the risk cancer, but actually also potentially had a superior effect in actually slowing down the progression of AMD. So these formulations are not available by prescription, but they can be bought over the counter. And there's lots of different types. There are those that come with up to 4 tablets a day, and there are also those that come in with 1 tablet a day. So there's lots of different versions of these supplements that you can suggest to your patients. But ultimately, the management of dry AMD is supportive in nature. If they are advanced, if it's somebody with one eye, these are patients who potentially may benefit from regular review in the secondary care clinic. But ultimately, there's not a lot of intervention that's going to happen for these patients. Now, neovascular AMD is a different disease essentially. Dry AMD can progress into neovascular AMD, or these patients can simply progress with neovascular AMD. And sometimes they present with neovascular AMD because actually they may have had dry AMD, which was asymptomatic. They had a break in Bruch's development of a CNV, which then leaked, and they had a very sudden, quick, dramatic drop in their vision. Now, the way to think about your Bruch's membrane is obviously if you go back to my macular OCT uh, session, you're not supposed to see it on an OCT. And if there is a retinal pigment epithelial detachment, then you might be able to see Bruch's underneath with that faint white line. Now, any break in Bruch's increases your risk of developing a CNV. So if you think of any disease that causes a break in Bruch's, a CNV is a potential complication, and with neovascular AMD, that's very typical. You've then got these sort of two main types of CNV. You've got your type 1 occult CNV, which starts in your choroid, comes into your sub-RPE space, and then your type 2, which then progresses through your RPE into the subretinal space. And your features are going to obviously depend on the type of CNV, though, therefore. So with your occult CNV, where it grows into the sub-RPE space, you may have a PED, as a pigment epithelial detachment. You may have some sub-RPE fluid, but because it's not pushed through the RPE, you shouldn't have any changes to the retina itself. Whereas with the type 2 or classic CNVs, where it grows into the subretinal space, you can get additionally subretinal fluid or intraretinal fluid as well. So the way your OCT looks can give you a clue as to what you're looking at. And there are certain FFA criteria as well, which you can read up on, which help you to kind of differentiate between type 1 and type 2 CNVs. But essentially, in terms of exam purposes, the key to differentiate is the extent to which that CNV has grown. So either to the sub-RPE space or through the retinal pigment epithelium. But there are also variants of the CNV, things like wrap lesions or PCV, which I'll go through later on. I wanted to take a moment just to talk about pigment epithelial detachments, which is what you're going to find quite often in patients with wet AMD. But there are lots of different types of PEDs. With wet AMD, what you're going to see most commonly is the serous PED, where you have this hyper-reflective area on the OCT. You have this dome-shaped pigment epithelial detachment. Fibrovascular pigment epithelial detachments are secondary to things like occult CNVs, and usually they look much less dome-shaped, so they're a bit more irregular in their shape. The sub-RPE space can actually be a bit more heterogeneous in terms of its reflectivity. You may not get this complete blackout, which you get in a serous PED. Hemorrhagic PEDs, you're going to get blood underneath that RPE, so there will almost certainly be a CNV. There's basically no version of a hemorrhagic PED which has happened without a CNV, and you get what looks like blood under the RPE, so something that's quite hyper-reflective. And these, especially if they're at the fovea, usually carry quite a poor prognosis. There are kind of attempts at treating hemorrhagic CNVs, things like TPA, for example, or even sometimes using air to try and displace the blood away from your fovea, because blood is very toxic, and blood in that area can essentially kill off your photoreceptors. So hemorrhagic PEDs unfortunately carry quite a poor prognosis, especially if they're at the fovea. And then finally, your drusenoid PEDs, which you'll see most commonly in patients with, for example, dry AMD. And that's where you have these soft drusen, they coalesce and they push that RPE upwards. So if we look here, you can see these very, very small drusenoid PEDs, but this is a patient with advanced AMD with geographic atrophy and complete loss of their outer retina there at the fovea. Whereas this is a patient here with a large PED. And the last thing to bear in mind is this thing about RPE tears. Now, large PEDs, if you think about it, that RPE is under a lot of stress, and that therefore carries the potential of breaking and tearing. Now, if an RPE tears happens outside of the foveal area, it may not actually be visually significant. But if it happens at the fovea, which is typically where you might find them, because if you're going to find an RPE tear, it will probably be on an OCT. It can be difficult to find these things clinically. Um, So if you're doing an OCT of the macula and you're finding an RPE tear at the foveal or extrafoveal area, these can really dramatically drop a patient's vision. So somebody who could be hovering at 618 to 636 can suddenly drop to hand movements or even PL because of a really bad RPE tear. And patients who are at risk of these are usually patients with bigger PEDs. So patients, for example, with PEDs of above 400 microns. And sometimes it's useful to bear these in mind because if a patient has quite a large PED, you're talking to the patient about the risk of an RPE tear once you start treating them because rapid reduction in fluid can cause these tears to happen. So, sometimes you might go for half dose anti-VEGFs for these patients to try and slow down the reduction of that fluid because you're worried about a tear happening once that fluid goes. So these things are clinically relevant because they do carry a poor prognosis if they tear, and they are at risk of tearing if they're quite large. So it's something worth explaining to your patients before starting them on treatment. So, how do you treat wet AMD? Most of you will have come across your anti-VEGFs, lots of different types, Avastin, Lucentis, Eylea, and Vabysmo. These are all different antibodies. And Vabysmo is your kind of dual action. It looks at anti-VEGF and anti-Ang2, whereas the rest of them are anti-VEGFs. And there's different kind of doses of these. There's, for example, aflibercept 2 milligrams, aflibercept 8 milligrams, and there are different indications for doing this. The nice guidelines do change regularly. The main thing to bear in mind if you're sitting, for example, the FRC Opt exams is to bear in mind those FRC Opt, those nice guidelines in terms of they mainly look at the visual acuity of the patient, the size of your CNV, the potential that you think that the anti-VEGF will actually make a difference to that patient as well. So there are certain guidelines that are used in terms of whether or not a patient fits the criteria for anti-VEGF treatment. And photodynamic therapy is really quite rarely used. It tends to be reserved for patients who've either declined the use of anti-VEGFs or, for example, are contraindicated for whatever reason. But it is quite rarely used these days in terms of using it to treat your typical wet neovascular AMD. Now, there are variants. So, retinal angiomatous proliferation, polypoidal choroidal vasculopathy, these are all kind of thought of as variants of neovascular AMD. But clinically, they're useful to differentiate because while your treatment is very similar, especially in the case of an RAP, or a RAP lesion, but prognostically for the patient, they can carry different they can carry a different prognosis. So retinal angiomatous proliferation. So the way to think about this, it's sort of the opposite of your typical CNV in that the actual neovascularization starts within the retina itself. So you get this intraretinal neovascularization that grows to the subretinal space, and then that grows into the choroid and then creates a CNV. So the direction of growth is essentially the opposite with an RAP. And then with a PCV, this is sort of if you're looking at something that looks very typical of NAMD, but actually the patient is a bit younger or the patient is of Asian or African descent, someone less likely you think to develop NAMD, you're probably looking at PCV, which is actually, from my understanding, typically underdiagnosed because these are patients who are being treated for just a classic wet AMD when actually they have PCV. The only way really to diagnose it for certain is by doing an ICG where you can see those choroidal vessels. These are patients who are going to have lots of hemorrhages, and if they're outside of the macula, you can actually sometimes, essentially just observe them. And otherwise, if it is at the macula, then actually what the research suggests is anti-VEGF combined with PDT is superior to anti-VEGF alone. And actually, where that's relevant is if you're treating somebody for NAMD and they've had 3 months of treatment and anti-VEGFs have done absolutely nothing, then these are patients who you really need to consider doing an ICG for if they've not had one, because you might be looking at PCV. And if they do have PCV, then you need to think about adding in PDT to their treatments. So before we sort of go on to the other vascular macular disorders, essentially the thing is with AMD is that dry AMD, it's mainly supportive in treatment. These are patients who, it's worth telling them they have this disease, that it is progressive. The progression is hard to predict in terms of the speed at which it progresses. But these are patients who are typically going to need cataract surgery. They carry a guarded prognosis because they do have changes in the back of the eye, and that's helpful for them to know. These are patients who you're going to consider giving things like an Amsler grid 2 to keep an eye on things in case they then develop distortions and they develop wet AMD. And while dry AMD makes up 90% of those with AMD, Wet AMD actually makes up 90% of severe vision loss with AMD. So those proportions are definitely swapped when it comes to actual vision loss. So dry AMD is 90% of cases with age-related macular degeneration. But if you're looking at age-related macular degeneration and severe sight loss, 90% of those are actually due to the neovascular type. So that neovascular type is really important to let the patient know what to watch out for, and then actually how you then go on to manage them. So, for the sort of second part of the discussion, I wanted to look at other vascular disorders at the macula. So, other things that can cause a CNV. And this is by no means an exhaustive list, but it's the things that you're going to come across in clinical practice if it's not wet AMD. And it's definitely things that are worth knowing for your exams. So, you have idiopathic CNV, MACTEL. Myopic CNV and angioid streaks. These are all things that can cause CNV at the back of the eye. They carry varying levels of different visual prognoses, but the treatment tends to be very similar across the board, with CNVs essentially being treated with anti-VEGFs. Now, idiopathic CNV, to be honest with you, this is essentially a diagnosis of exclusion. These are patients who you need to rule out things like angioid streaks, rule out pathological myopia, rule out things like MACTEL, and it's typically patients who are going to be quite young, and these are also going to be unilateral cases most often. And like I said, you want to exclude other potential causes first, and a lot of these can actually spontaneously resolve, but if they are foveal lesions, and these are patients who you're worried about having long-term effects of having that CNV not being treated, anti-VEGFs are the mainstay of your treatment. But remember to rule out other causes, which we're discussing here today. Now, macular telangiectasia is essentially exactly what it says. It's telangiectasic vessels in the macula, potentially some aneurysms as well. And there are sort of three types to think about, but types one and two are things that you're going to come across more commonly. Type one is a rarer type. And the useful way to remember these things is type 1 is unilateral, type 2 is bilateral. And that type 1 unilateral disease tends to be aneurysms. And you're essentially going to treat areas that leak, usually with some laser, because these lesions tend to be actually more peripheral. They don't tend to be foveal or parafoveal. So laser is usually a safe way of treating these leaking aneurysms. But if you are looking at a foveal aneurysm that is leaking, that you can't really treat safely with laser, then anti-VEGFs are helpful. Type 2 MACTEL is where you get things that are usually bilateral. It's the much more common type of macular telangiectasia, and it tends to be closer to the fovea, which is why the treatment tends to be more anti-VEGFs because laser is less safe to use. And actually, what you might find is you're getting these intraretinal cysts, as you can see in these pictures, but they look quite distinct from something like CMO. It doesn't really look typical to that. And if you catch them quite early on, what you'll find is that these cysts tend to start off temporally and then work their way around the fovea. So if you look at this picture here, you can see that this is the nasal side. As you can see, the thicker nerve fiber layer. This is where the disc of the patient is. This is the temporal retina. And these sort of intraretinal spaces will start temporally and then slowly work their way around the fovea. And these are patients who can eventually end up, because of these cystic spaces growing and coalescing, they can even end up with something like a macular hole. And so these are patients who are typically going to treat with anti-VEGFs because, like I said, the lesions tend to be much closer to the fovea and much more difficult to treat with laser. Type 3 is a much rarer type. It's sort of an academic thing, really. It's very unlikely you're going to come across this sort of thing. And actually, rather than it being telangiectasia, it's actually an occlusive process, with the capillary beds actually having occlusive changes. And like I said, it's very rare. Then, when it comes to myopic CNV, the way to think about myopia is you've got things like high myopia and then sort of your pathological myopia. High myopia is anybody with a refractive change of more than -6, or an axial length of over 26. And then once their myopia reaches a -8 or a 32 millimeters in terms of axial length, you're definitely looking at pathological myopia. And there are things that are associated with high myopia. So you're looking at things like Down syndrome, Sticklers, Marfan's, Ehlers-Danlos loss. And really, these connective tissue diseases are associated with high myopia because if you think about it, the sort of infrastructure of your sclera, that scaffolding, that connective tissue, you have a disorder there. Everything's a bit weaker, everything's a bit stretchier, and you're more likely to end up with these very large eyes. And your features of myopia, you get this sort of pale fundus. Your RPE is essentially stretched. You can see those choroidal vessels underneath. Your discs may look slightly different. They may be tilted. You may have some peripapillary atrophy. Importantly, in the sort of peripheral retina, you may end up with lattice degeneration, potentially even things like retinal holes, Fuchs spots. Lacquer cracks are something that you tend to see actually in the macula. They represent breaks in your Bruch's membrane. And this is essentially where, again, this risk of developing a CNV comes from, because you essentially have a very stretched RPE, a stretched eye, and these breaks in the Bruch's can give rise to CNV. You can have retinoschisis, which progresses into a macular hole. And like I said, for this discussion, your CNV can grow. Now, the treatment of CNV in a myopic situation is essentially anti-VEGFs again. But for these patients, sometimes they carry a slightly better prognosis. The CNVs tend to be extrafoveal. These are younger patients, but they can still really dramatically drop the vision of a patient. And because these patients are younger, these are potentially patients who are going to need treatment for much longer, patients who are going to develop cataracts at a much earlier stage. They're patients who are more likely to develop glaucoma. So pathological myopia can really be quite dramatically profound in terms of effect on the life of the patient. Those retinal tears can cause retinal detachments, and everything generally in this eye is essentially different to your normal eye. And then finally, for this discussion, what I wanted to talk about was angioid streaks. Again, there's lots of different causes, but these are essentially breaks in Bruch's membrane, and you can see them. They sometimes start at the disc and they sort of reach out and branch across the retina. And there are lots of different causes. For the purposes of your exams, these tend to be things like pseudoxanthoma elasticum, Paget's disease of the bones, your hemoglobinopathies, things like sickle cell. They can be completely idiopathic as well. And because it's a break in your Bruch's, it sort of progresses. It can actually even cause choroidal rupture, with very sudden drop in vision, especially if that choroidal rupture is within the macula or near the fovea. And again, because you've got a break in Bruch's, these are patients that can lead to having CNV. Angioid streaks typically can just benefit from routine observation. If they're not causing any problems, they don't need to be, you don't need to worry about them. But if they are causing CNV, then again, that treatment is with anti-VEGFs. So just to sort of summarize our discussion on AMD and your sort of other causes of CNVs, AMD is a very common disease, and it can actually really dramatically change the vision of the patient. So it's something that's really worth educating your patients on, getting them in touch with support groups so that they can actually understand their disease much better. But the thing is the important thing to remember with CNV is not to sort of push everybody down the bucket or the rabbit hole of them having wet AMD. CNV has a lot of different causes, and there are a lot of different pathologies that can cause a CNV. And sometimes the characteristics of the patient, the characteristics of the eye can lead you down different differentials. So, if you're looking at a typical elderly patient with bilateral disease, yes, you are probably looking at neovascular AMD, but in the younger patients, in patients from African or Asian backgrounds, patients with other systemic disorders, patients with high myopia, you may be looking at a different cause of the CNV. And while we've shown that, yeah, okay, fine, your treatment, it tends to be anti-VEGFs, the specific cause can actually help sort of narrow your discussion with the patient in terms of what sort of prognosis are we actually expecting for this patient? Do we expect the patient to respond to the treatment? Do we expect the patient to have a poor visual prognosis? Do we expect the patient to have a better visual prognosis? Is this a patient who actually needs PDT as well as the anti-VEGF? And these discussions are actually really helpful because these patients are very anxious, these patients are very worried, and the last thing that you want to do is start them on treatment with the promise of getting better, when actually that promise can't necessarily be given, and the prognosis differs depending on the underlying pathology that's actually driven the development of that CNV. So it's worth just taking a step back, and before you just decide to inject and send the patient home, it's worth just thinking about, what do I actually think has driven the development of the CNV? What am I telling this patient in terms of what they can expect? And is there anything that they can do, or is there anything that they need to watch out for when it comes to this specific type of CNV? So thanks for joining. Please do remember to give me some feedback. There's a link in the description. It takes just 2 minutes. Please just do it now. You can just click it and fill it out. And at the end of the feedback form, there's also an opportunity for you to just send in some suggestions as to what you might want me to go through in the future. So this was a tutorial looking at your CNVs, specifically looking at AMD, and I hope you found it useful, and we'll see you at the next one. Thank you very much for joining.